Good afternoon, everyone, respected jury members, teachers, and everyone gathered here. Today, I'll be presenting my paper on the title, Comparative Study of Transdermal Buprenorphine and Fentanyl patch for post-operative analgesia in abdominal surgeries under general anesthesia. So, post-operative pain is one of the main concerns for the patient undergoing any major surgery. Satisfactory perioperative analgesia improves the surgical outcome by reducing the morbidity and organ dysfunction. Pain can hamper the normal recovery process and extend the length of the hospital stay, contribute towards the patient dissatisfaction, causes a negative perception of the hospital performance, and increases the healthcare utilization cost. Opioid therapy is still the main approach for the management of moderate to severe post-operative pain. Transdermal drug delivery systems are simple, non-invasive, and compliant method of the drug delivery designed to provide a sustained drug release for a prolonged period, resulting in constant plasma concentrations. Transdermal drug delivery system overcome the pharmacokinetic problems of the oral and parenteral routes. Buprenorphine is a semi-synthetic derivative of saline, 75 to 100 times more potent than morphine, and causes less respiratory depression. Buprenorphine is incorporated into an adhesive polymer matrix, which is continuously released into the systemic circulation. Fentanyl is a synthetic opioid, 75 to 100 times more potent as compared to morphine, and fentanyl transdermal drug delivery system provides analgesia in a discrete, convenient, non-invasive, and safe manner. The objectives of my study was to compare the efficacy of transdermal buprenorphine and fentanyl patch for post-operative pain relief, to observe the effect of the two study drugs on hemodynamic parameters, and to observe the associated side effects of the two study drugs. The study was conducted after getting approval from the Research Ethics Board, RIMS, and registration was done in Clinical Trial Registry of India. The study design was a randomized single-blinded study, and the study populations were all the patients undergoing elective abdominal surgeries under general anesthesia. The inclusion criteria includes ASA physical status 1 and 2, age of 20 to 60 years, and exclusion criteria includes history of skin allergy and pregnant patient. Sample size was calculated based on a study done by Arsad et al., and 40 patients in each group was got using the formula shown. A computer-generated randomization was used by logging on to randomization.com, and as the sample size for each group is 40, so we have entered 1 as the lowest integer, and 80 has the highest integer, and divided them into 2 blocks, and the patients were allocated into either of the group. Group A received buprenorphine patch 10 microgram per hour, and Group B received fentanyl patch 25 microgram per hour. Pre-operative visit was done a day before surgery, and a good rapport was established. Eligible patients fulfilling the inclusion criteria were informed about the study, and consent was sought. TDS was applied 12 hours prior to surgery on the hairless area of the right upper arm of the patient. On the day of surgery, in the perioperative holding area, IVSS is secured, and patients were premedicated using injection glycopyrrolate IM and ondansetron IV. On arrival to the operation theater, baseline monitoring of the heart rate, BP, oxygen saturation, and ECG were checked. Pre-oxygenation was given for 3 minutes, and anesthesia was induced using 1% propofol and succinylcholine 15 mg per kg. Anesthesia was maintained with balanced technique of nitrous oxide, sevoflurane, and injection becronium bromide. The VAS score was assessed immediately at the end of the surgery, 1 hour, 2 hour, 4 hour, 6 hour, 12 hour of the surgery, and on the second day and third day of the surgery. And injection diclofenac was given whenever the VAS score was found to be more than or equal to 4. Ramsey sedation score was used for determination of the sedation of the patient. Data were collected and analyzed using SPSS version 21, and student t-test was used for continuous data. Chi-square test was used for the categorical data, and a p-value of less than 0.05 was considered as statistically significant. Now coming to result, Table 1 shows the demographic characteristics of the two groups, and as you can see, what the groups are incomparable. And Table 2 shows the comparison of the VAS score between the two groups, and as you can see on the Group A, the VAS score is lower as compared to Group B, and from the end of the surgery to 6 hours after surgery, the p-value is less than 0.05, hence it is significant, and from 12 hours onwards, it is comparable. Table 3 shows the comparison of the Ramsey sedation score between the two groups, and it is almost insignificant. Figure 4 shows the comparison of the mean heart rate in between the two groups, which is almost comparable. And Figure 5 shows the comparison of the mean arterial pressure in between the two groups, which is almost comparable. Table 6 shows the associated adverse events, and as you can see, in Group B, there is high incidence of nausea, vomiting, and constipation, and the incidence of nausea was almost significant with a p-value of 0.02. Coming to discussion, there was no statistically significant difference found between the two groups in regard to the demographic profile and baseline characteristics. The comparison of the post-operative VAS scores at all time duration found that Group A have a lower VAS score than that of the Group B. And the difference in VAS scores among the two groups were found statistically significant from the end of the surgery to 6 hours after surgery. However, from the 12 hours of the surgery, both the groups have comparable VAS scores. The result of the VAS score suggested that both approaches were effective in controlling the post-operative pain, but buprenorphine was better in this regard. 2 patients in Group A and 12 patients in Group B required a single dose of rescue analgesics, and the comparison of the RIMS sedation score between the two groups showed that there was no statistically significant changes, and all the patients in both the groups were calm, comfortable. Comparisons of the heart rate and MAP shows no statistically significant difference. Nausea, vomiting, and constipation were the main side effect of the study drugs. Now, coming to the limitation of the study, there was small sample size, and age more than 60 years were not included in the study, and hence the effect of the transdermal opioids in elderly patients was not studied, and the plasma level of the drugs were not measured. To conclude, for effective abdominal surgery under general anesthesia, transdermal buprenorphine 10 microgram and fentanyl 25 microgram per hour administered 12 hours prior to surgery is safe, reliable, maintaining hemodynamic stability. However, the significant nausea warranting the need for rescue antiemetics seen with transdermal fentanyl makes buprenorphine better. These are my references. Thank you.